Just one thing is that I don't take questions at the end at all. So there's no question session at the end. The question session is as the slides goes by. So stop, ask me if something is not clear, and we will talk about it and still try to finish everything on time. We don't want to go on a tangent and talk about something else. And hopefully we would like to make it a little interactive rather than me talking, and I thought that at least, who was the speaker? The guest left?
Yes.
Thank God. At least I thought that 50% were actually looking down or were on the cell phones. I was just trying to count how many people were looking down. So let's talk, get to know this. So what are we going to learn today is that I again have a struggle with people how they manage simple gastroenteritis. So we will talk about the difference between traditional versus rapid versus ultra rapid hydration in the ED. We are at this point now, so there should be some clarification as to how we are going to do that. Should we give normal saline as a bolus? Should we give normal saline dextrose 5 as a bolus, and where we stand there? And that now, in my opinion, the 1/5, the 0.18, 0.45 for maintenance is obsolete and should never be used again in medicine for maintenance. So we'll talk about some time on that. And then we will go through the concept of hypoglycemia and ketosis. It's a disease, it's a process. And then of course, if people who come only with vomiting, what does the word paradoxical aciduria means and the pathophysiology behind that. And we'll see how that goes. Okay, I know, simple definition, diarrhea. We need to define that. It's defined by the WHO as having 3 or more loose or liquid stools per day, or having more stools than is normal for that person. And again, through the World Gastroenterology Organization, is defined as abnormally frequent discharge of semi-solid or fluid fecal matter from the bowel, lasting less than 14 days. They're very specific about the days. This is my favorite. I think this is the most important. We talk about take home at the same time. Enteritis is an integral part of definition of gastroenteritis and not vomiting. Vomiting of 24 hours without diarrhea is worrisome and should be worrisome. You know how we see a 6-month-old vomiting times 4. Somehow we give an ounce of Pedialyte or apple juice, patient takes it, we call it gastritis, send the patient home. Comes back next day, mommy said he's kept vomiting, but we called it gastritis. In our mind, I think the gastritis diagnosis equals gastroenteritis. So I think we put this thing in our head. I think we learn to make symptom diagnosis in pediatrics. I think vomiting is a better word. Vomiting, I don't know why. Give clear instructions. If vomiting is not followed by diarrhea in 24 hours, which it generally should, we would like you to come back for reevaluation. I can show you chart after chart where we have misconception. I can show you chart after chart where child develops fever and comes back with otitis media or UTI or missed appendicitis. So never say gastritis. Say gastritis however you want to do it, but be cognizant of the fact that vomiting alone is not okay. We all know the complications, and we'll talk about it: dehydration, hypoglycemia, and of course the phenomenon of paradoxical aciduria. We know this. 3 types of dehydration: hypotonic or hyponatremia, as a primary loss of electrolytes, sodium in particular. Hypertonia or hypertonic or hypernatremia is primary loss of more water in diarrhea. And of course isotonic, which is actually the most common. Almost 90-95% would fall in this category of isonatremia. The severity of dehydration is classified by WHO into 3 clinical categories. The reason is WHO is that we all travel a lot, and I think we should be familiar with that. No dehydration in real sense is less than 5%. They're called mild to moderate. So remember we used to say mild, moderate, severe. Now it is no dehydration. Mild to moderate is between 5 and 10, and then severe dehydration would be more than 10%. And then how do I gauge how dehydrated you are? So in the United States, we use this Gorlick scale of dehydration. It's a 4-point or a 10-point. But across the world, people use WHO and something called as clinical dehydration scale. I'm just putting it up there. Most of us don't know this. There's no need to remember those names. We just look at you and say, you're not passing urine, you're dehydrated. You know, we make our own ways of doing things. But I think Gorlick, and we talk about the 4-point, is an easy, fast way, very well validated in the United States, and I think one should at least know this one. So there are 10 items. Appearance, refill, tears, mucous membrane, eyes, breathing, quality, skin elasticity, heart rate, and urine output. And the one in the italic font, the first 4, is what people talk about. And the 4-point scale here is more than 2, more than 5%, more than 3, more than 10%. So alert, normal, present, moist, restless, lethargic, and so on. Just kind of, at least nothing to take home is to take home this 4 things to remember. And you can always do an extensive 10-point. People leave it for research most of the time. And then the WHO is a simpler one also. It just looks at eye, thirst, and field it, and then ABC, and it tells you what to do, and it's much simpler way. Fewer than 2 signs, no dehydration, more than 2, moderate dehydration. Sorry, in column B, any 2, and in column C, any 2 would be severe dehydration. So another easy way of knowing this stuff. And the third one is called a clinical dehydration scale that also looks at 3 things. And so, no dehydration 1 to 4 and 5 to 8. Gorley 4-point would be the way to look at it. Everybody has a preference of doing it. So. But look at this. In one study they went to West Africa and they said, let's see how it is. So look at WHO, 79 and 50% for severe and moderate dehydration, the sensitivity and the specificity. The 4-point and 10-point, 64-21 versus 69-89. It's all over the place, really. It's not there. So how do we gauge? Anybody would say, how do you gauge moderate dehydration in the ED here? Anybody has seen a patient of gastroenteritis in the last 30 days? Any of the first-year residents tell me how they come to a conclusion where I'm 5% or 10%? Come on, you must be doing something, right? You can't say, oh, we just looked at it, and you know, Dr. Tejani said so, and so we said 5%. So can't be like that, right? Yes, yes.
General appearance, tears, cat refill, urine output subjectively from the parents.
Okay, okay.
And heart rate.
Correct. So most of us look at the first symptom would be thirst. I am tachycardic, less than 5%. I'm not passing urine at all in last 12 hours or so. Maybe I'm moderate. I have sunken eyes. I'm sort of sleepy a lot. Maybe you are around 5 to 10%, kind of. Is a rough guesstimate we try to make, which is pretty fine, just an idea of how to get dehydrated. So, but it would be nice for us to have something to look at and put things down. So, yeah, go.
I know you want to discussion, so I'm
talk about it.
I'm interested. So for me, anyway, I feel like it's interesting that there's a scale, but I want to know what you think. But some of those, I think, are even if I have one of them, make me a little more concerned, such as tachycardia or lethargy or not. So even if I have one of those, I'm more concerned. So I was just wondering how you feel how the scale works in terms of your actual management.
So I think the scales are good to classify. See, one thing we'll talk about is that when I come with vomiting, the question is it inability to tolerate PO? And my compensatory mechanism has gone through, so I'm tachycardic and I'm not dehydrated at all. That doesn't bother me. Versus I am literally, it's not inability to tolerate PO or that, plus I'm dehydrated. Then the approach becomes very different. So simple tachycardia, I'm not sure if it bothers me a lot. But once I start to see 12, 18 hours of no urine output, the child is more sleepier than usual, we talk about ketonemia and stuff like that, then my red flags go up a lot. So I think it's a matter of choosing one or the other and then trying to practice it over time and getting good at this. Like he said, he has these 4 parameters to look at that he looks at and classifies himself. I think we should be able to determine with any of the scores you like, we should be able to categorize them less than 5, moderate. So that gives you a good idea as to how your intervention would be like. So just simple tachycardia for me is like, oh, okay. And any comments from my fellows here? Or anyone want to say something, please add on. So of course the treatment ideally would be, if you're like this, I would like to be managed with oral hydration with, this is And it's amazing how we don't practice that. So they did a survey between Canadian physicians and American physicians. And it seems like 79% of Canadian physicians would like to try oral hydration, and 39% of US physicians like oral hydration solutions. So it's really a stark difference between how we practice. So I think we need to get used to this. So how much to give? I think it is important to know WHO recommends giving children under 2 to 4 ounces of fluid. And we'll talk about that. Following each bowel movement. People we ask, how much am I going to send you home? When I send a patient home, what do I tell them? You're having 6 diarrhea a day and you're vomiting 5 times a day. So the magic number out of air is around 10 ml per kilo for diarrhea, and about 2 ml per kilo for vomiting is a good number to remember if you would like to remember. So you need to give them some idea of how much to take to replace. So at the end of the day, it is 0-0. The patients are well hydrated. Versus you do under 2, we'll do 2 to 4 ounces. Over that, we'll do 4 to 8 ounces is one way of doing it, right? And this is 2009 recommendation. A recent advance in the management of gastroenteritis has been changed to rapid oral hydration therapy for a 4-hour period, which is the first line of treatment for all children with gastroenteritis, right? And look, American Academy of Pediatrics recommends 5 ml per minute. Now, it's very difficult to give 5 ml per minute by the mom. Someone like me says, here is a plastic cup, an ounce. Have you seen those ounce plastic cup, medication cup? It's 30 ml. Give 1 cup every 5 minutes. It's the same way of doing it. And you would like to push almost 300 ml per hour. And again, I think, we all know this, but I think we need to go over this. The co-transport of glucose into intestinal epithelial cells requires sodium. 2 sodium ions and 1 molecule of glucose are transported together. Without glucose, intestinal sodium is not absorbed. That is why ORS includes both sodium and glucose. And once that goes in, 100 of water molecules move into the epithelium. And of course, this helps even while diarrhea continues. This is what helps us achieve hydration. And it's good to know this. Again, the types of oral hydration that we use is ORS, which was the standard till before 2009, and then now we have a WHO recommended low osmolality ORS, and Pedialyte and Gatorade. Some people even advocate that. Let's look at that. So, in 2003, WHO and UNICEF recommended that the osmolality of ORS be reduced from 311, which was the usual ORS, to 245. And why? Because it reduces stool volume in children with diarrhea by about 25% and the need for IV therapy by about 30% when compared to standard ORS. The incidence of vomiting is also reduced. Okay. Just telling you that this is why we do what we are doing right now. We're not going to that. As for essentially osmolarity and osmolality, I'm going to use the word interchangeably for now. Just to bring your attention to blood osmolality, it is how much dissolved BUN, glucose, and sodium are, and our blood osmolality is 275 to 303. So we are definitely using a hypotonic solution when we are trying to rehydrate someone. And this is the composition we can look at. So ORS, the usual used to be glucose was 111, sodium look at 90 millicurie. This was done when cholera was rampant and people actually took the cholera stool and they said, how much sodium do I have in cholera stool? How much potassium? And then according to, based on that, the original ORS came through. And the kind of Pedialyte that we do now is look at the osmolality is 250, the osmolality of the ORS, WHO recognized is 245, very close. Gatorade is 350, and if you look at sodium, it's very, very less. It's almost half, but look at the glucose, it's a lot. We would like 1-to-1 osmolar ratio to really go through. So that's FYI what we have there. And then of course, look at the apple juice. The osmolality that we like to do, I like to do a lot also in my PGD at UHP. We like to give apple juice to everybody with diarrhea. Look at the osmolality we are dealing with is 705. And why are we concerned? Because this increases the osmotic load and we probably should worsen diarrhea. Right? Okay. People do that also a lot. If you ever go to Haiti or anywhere else, we can do this. 6 level teaspoons of sugar and about half a teaspoon of salt in a liter of water will make ORS. It's a very cheap thing to do also. If parents come and say we can't afford Pedialyte or we can't afford this, so it's a very easy thing to do. Let's talk about a second complication of hypoglycemia. Sleepy infant with gastroenteritis is clinically hypoglycemia till proven otherwise. I never want you to forget that. Anytime I use the word I am not alert, I am not inconsolable, I am irritable, I have poor eye contact, for me all of this means that I am not oxygenating, ventilating my brain. And the food for my brain is oxygen and glucose. And I want you to check my glucose at all times. The glycogen load in the liver generally is supposed to be 4 to 8 microgram per kilogram per minute, and a small infant can empty it in 6 to 8 hours of starvation. And a child will do so in 12 to 18 hours. So when they are vomiting, having diarrhea and not taking anything at all, they can potentially not get any glucose. Load will really go down. Once the glucose load will go down, they will present with lethargy, irritability, sleeping. All of this is like 3 a.m. in the morning, he's sleepy, yes, he's sleepy, but your mind says you're not oxygenating, perfusing your brain. I need to check your glucose because food is not there. That's the concept you should take home from that. And of course, I think it is important, again, so it is 40 milligram or less if you are symptomatic or symptoms present indicate 60 milligrams. We know that they can use ketones. 5% of children can be below 60 in the morning fasting state. Just wanted to bring that up. We would all like anybody after first day of birth, we want them to keep above 60 at all times. Now this is something I know everybody understands, but this is an issue commonly we face in pediatric where we talk about hypoglycemia with ketosis versus actually a condition called ketotic hypoglycemia. I do not know if it's actually a disease or not, or it's just an exaggerated response. Thought we will spend some time talking about it. So what happens, I have a falling blood glucose, I have a reduction of insulin because I have no glucose, the insulin shuts down, and then I have this glucagon, adrenaline and other stuff come in my blood, and they start making glycogenolysis and gluconeogenesis in the liver, and of course there is lipolysis starts to occur in my adipose tissue. Everybody's clear about this part? Okay. Now what happens? Now of course my lipids are broken down to triglycerides that turn into fatty acids, and then of course I'm making these ketone bodies. And of course ketones can be used as an alternate fuel, but this high level in the blood we use the word ketosis. So actually it's a normal response. The problem to identify is that when this happens, the absence of ketosis, when you get hypoglycemia, then the diagnosis would be excessive insulin or a fatty acid oxidation disorder. It's a very quick way of picking something up just as a remembrance. So that is what we deal with, right? That's what happens to kids when they get that. And the problem is that once ketosis sets in, what happens? You develop lethargy, anorexia, vomiting, and then you can develop something called as neuroglycopenia, which is about less than 10 milligram per deciliter of glucose in the brain cells. When that happens, it will cause seizures. So really you have to really drop down to a very low level. But a potential is there, and you never want to get there. And that's why I wanted to make sure that when you see a child with vomiting or diarrhea, you are going to make sure that he is, as I say, perfusing his brain. So there is another thing called as ketotic hypoglycemia that commonly we used to see, haven't seen in a long time now. Recurrent hypoglycemic symptoms with ketosis in young children, cause remains uncertain. More common causes of hypoglycemia in this age range, they usually come in with this much of glucose, bicarb is low, urine is positive, other tests are normal, I give them saline and dextrose, they go away. Generally they present earlier on as saying, oh, you had a virus or you had gastroenteritis. As to why it happens, over time, multiple episodes, parents are able to pick it up very quickly. It can happen because of extended fasting or viral infection. Generally your weight percentile is below your height percentile. And of course we have this issue here, so it doesn't happen with us commonly. Of course you have to rule out the following conditions of growth hormone, hypopituitarism, adrenal insufficiency. When all of these are done, that is a diagnosis of exclusion, so they should probably see an endocrinologist when this happens, I guess. The electrolyte abnormalities I'm not going to, but again, these are the normal range to look at. And just curiously, we can start from here. So I have hyperkalemia. What is the definition of hyperkalemia? Anybody? Definition of hyperkalemia? Starts at what level? 5.5. Okay, and the first change I will see in the EKG. Peak T waves, then my level goes to 6.5. What am I going to see? Not widened QRS, that's not correct answer. Yes, widened T waves or absent T waves, and then the third phase will be that. In pediatric, most of us don't worry about it. My colleagues can help me. I don't care about potassium of 7 or less. I really don't care. I haven't seen anything happen. Maybe if you go over 7, I start to little worry about it. Rocklin, is there a magic number you have in your head for hyperkalemia? You start to really care. I'm going to care about this one.
Anything in the computer that's red, I get anxious.
Okay. So that is his approach. He does it that way. For me, it's like I don't know what to do less than 7 in P's. Everything starts after 7, 7.5, 8, 8.5, and of course 9 and above should probably kill you. Good. Then a question about vomiting and paradoxical hype. This is very commonly we see in pyloric stenosis, right? And I think it's an important concept because if you go abroad and work somewhere else, and there's no test to do, the only thing you can get is a dip urine, and it tells you a lot. It tells you the dehydration status, it tells you the potassium level in the blood, it tells you a lot of stuff. So I think this concept needs to be clear. We'll put a physiology to this. And so this is what happens. Everybody just spend a couple of minutes looking at it. We are saying you become hypochloremic, then you get alkalotic, then you get hyponatremic and hypokalemic. Instead of passing, because I should be passing urine that should be alkalotic because I have metabolic alkalosis, but when you check my urine,